Hello and welcome everyone to our SimCity rounds for the month of September. It's a real joy for me to introduce our presenter this month. It's Dr. Fahad Alam, who's been with Sunnybrook since 2014 as an anesthesiologist and medical education researcher. He's got a special interest in medical education, curriculum design, simulation, and technology-enhanced learning. He's also an assistant professor in the Department of Anesthesiology and Pain Medicine at the University of Toronto. Dr. Alam completed a fellowship at the Wilson Centre for Research in Medical Education. He received a clinical investigator certification from the University of Toronto, a diploma in medical education from the University of Dundee, and a master's degree in translational research through the Institute of Medical Sciences at the University of Toronto. Dr. Alam has been awarded numerous competitive grants, over $500,000 worth, with many corresponding publications. As chair of the Simulation and Education section of the Canadian Anesthesiologist Society and medical and research director of the Sunnybrook Simulation Centre, Dr. Alam leads innovative education and research initiatives across Canada. He is the co-founder and director of the collaborative Human Immersive Interactions Lab and an immersive reality academic creation and research lab with a special focus on enhancing patient and learner experience and delivery of care. So thank you so much, Fahad, for being with us today, and I'm going to pass it to you.
Well, first of all, thanks for having me. Like I was saying, I have a run of talks for the next 6 weeks, and this is probably the one that I was looking forward to the most, a friendly, happy crowd that I kind of relate to. So I'm glad I was asked to be here, and I'm really glad to see a lot of friendly faces and our sim team from Sunnybrook, who a lot of this work couldn't have been done without. So I'm just going to share my screen, and then we'll start. And
so we're sending you lots of love while you get that going. And just to add that we'll be recording this and posting it on our YouTube channel. So if you have any colleagues who are upset that they're not here today, they won't miss out. They can.
Perfect. I'll let them know, because I did let my colleagues know, and they're like, "We're in the OR. Who gets out at noon?" I was like, "I don't know."
So we'll forward you the link to the recording. That's perfect.
But you guys can see my screen then, I'm assuming, right? All right. Okay, so let's start. So again, my name is Fahad. I'm an anesthesiologist, and my life is medical education and technology enhanced learning. I could talk about it all day because I feel like it's so cool, but at the same time, we kind of have to get past the cool factor, and that's kind of, and figure out how we can use this technology properly. And that'll kind of be like the theme of my talk today. So let's start. So first disclaimer, I virtually have none, and the pun's intended, because other than this being a huge topic, I don't really have any other disclosures other than that we've given workshops over multiple days on this topic. So I try to focus on VR and AR and avoiding mixed reality today, because it's a topic and a definition of mixed reality that's still in debate. So I'm going to try and keep this engaging from sticking to VR and AR. So the lamppost that we'll start with first, or pillar number one, is where do we come from and why do we even care about immersive learning environments in the new competency by design model? So why should we care? So not only in the current climate of virtual learning, but also in medicine, we have taken somewhat of an archaic approach that once we pass our exams, no matter what specialty or healthcare member you are, we're kind of good for life. You know, retrospective reviews on clinical outcomes, correlated age, as well as physiological changes that start to deteriorate as we go across and move along in our careers, and which reduction in our performance. So basically, we get shot out of a cannon, we're doing really well, and then slowly we start to come down. Now, how fast do we come down in terms of our performance? Could be right away, could be slow. Everyone's different. And I'm going to do a shameless plug here. We actually published a paper a few months ago in the BJA looking at acute care physicians, practicing acute care physician, which is ICU, anesthesia, and emerge, to see how they function in terms of correlation with age and time from exam. And we found this exact note, that our performance starts to decline as we move forward from and further from the time that we graduated. So we should start to care, because we should start to look for innovative methods to educate ourselves and our colleagues and our peers and our trainees. So let's look back at the history of where we kind of came from. So we know in the 70s, we got Harvey, and we moved on to full mannequin-based sims in the 90s with Dr. Gaba. We started getting more procedural-based virtual and part task trainers, and even computer avatars. But how long did it take us to really start using full body mannequin sims? Quite a long time. And everyone here who's probably listening to me right now kind of knows that. And how much are we using avatars nowadays? Is Second Life, which was like the medical and is the medical virtual avatar software, and it was sold to be the next great thing. Is it on everyone's desktops right now? No, because there's a problem when it comes to knowledge translation of new technology in medicine. And I kind of like to say that the problem is part of what we call part of the Gartner hype cycle. And any new technology, it really kind of goes this. It goes through where, we get a technology trigger, like with the advent of the internet in the 90s. We get really excited. We get a peak of inflated expectations. With the internet, we got very excited. We took all our knowledge that we had in our brains and we threw on the internet with our PowerPoint and everything and said, this is e-learning. Then all of a sudden it goes through a trough of disillusionment, right? And we're figure out, oh, wait, maybe that wasn't the best way to do e-learning by just putting a PowerPoint online. Then we're trying to push towards a slope of enlightenment. We kind of go backwards and say, okay, what's the best way to form our e-learning platforms based on learning theory and medical education theory and intelligent-based design to get to finding the plateau of productivity. So what our goal is, as well as everyone here, is to try to push immersive learning environments past that peak of inflated expectations. I think we're kind of still at the peak of inflated expectations right now, pass through the trough of disillusionment and get to the plateau of productivity really quickly. And what I'm trying to say is don't let the technology lead you. Everything I show you today is going to be cool. It's going to be, oh, great, I want to get my hands on this. But it's just a toy unless you create it with intelligent-based design and you really think about why you're using it and what you're using and how you're using it. So if you take anything away, please take this thought. Don't let the technology lead you. Let you lead the technology. So today I'm going to define immersive reality and its various forms. Focusing on VR and AR, which is virtual reality and augmented reality. I'm going to differentiate between virtual reality and augmented reality and its forms through examples. And then I'm going to discuss the importance of learning theory that supports immersive reality and why we should be using it, how we should be using it. And then I'm going to identify strategies supporting its use in health professions education and kind of discuss a high-level overview of how we can incorporate that into your curriculums. Now, sorry, my dog's barking in the background. But if you're here thinking that I'm going to show you how to develop and do software coding, then this talk is not that. And we can talk about that afterwards. So lamppost number 2, let's talk about the definitions and the levels of immersion. So I'm going to start off with focusing on some definitions, brief examples at virtual reality, augmented reality, and then really get to the concept of immersion and immersive reality and why that's important. So let's start with virtual reality. Like, when I do this in person, I ask who really knows what virtual reality is, and most of the crowd that's out there, they put their hand up and say, I know what virtual reality is, but then as I go through this talk, people realize that there's such a broad definition and such different levels of immersion of what VR really means. So the concept of virtual reality has long been established within healthcare and other industries. But what constitutes VR is vague because of the technological limitations that we've had to overcome. Traditionally, the VR label has been generally applied to any learning environment created with any immersive elements. Immersion is simply like creating the sense of presence, of being in that zone or in that environment that might not actually be real. In the VR context, in itself, is described as placing an individual in a VR system with images, sound, stimuli that creates the perception of being physically present in a non-physical world. The manner and degree in which this has been achieved in healthcare education in the past has been extremely heterogeneous. And it's been mainly limited to students viewing a two-dimensional screen with a virtual image of a simulated task to be practiced. And this has been very innovative in terms of leading the way in surgical or procedural-based specialties. So I'm sure most sim centers have these lap sims or some form thereof, where you have a 2D screen, you have haptic tools that practice and do laparoscopic surgery. Now, is this virtual reality? Yes, it is a form of virtual reality, primitive form, but it's an early form, and that's where most of the literature has been based on. Same thing when we do haptic feedback with fiber optic prongs and virtual 2D screens. People consider this VR, and it is. It's an early form of VR. But what's changed over the past 10, 15 years now is that the technology has progressed so we can now have higher processing power, more graphics, decrease latency, and put basically computers into headsets at a portable, cost-effective, in a portable, cost-effective means, so that we can achieve a greater sense of immersion. The key principle that I think affords learning. I view the principle of immersion, the immersive reality equivalent to what we used to say fidelity, whether you believe in that word or not, in mannequin-based simulation. So let's talk about virtual reality and the levels of immersion in virtual reality. On the left, we kind of say virtual reality with the 2D screen. So, your laparoscopic simulators. You have those haptic tools, you're looking at a 2D screen, and you're interacting with it. Then, as you move on to more immersion, is VR 360 recordings. You take 360 cameras and watch in a passive way, usually with a head-mounted display, whether it be a Google Cardboard or more high-tech one. It's kind of like modeling or observational learning on steroids. Then you take the next level, which is still the VR 360 recording, but you can have interactive questions. It can respond to you. You can have nodes in it where you can use your eyes or a remote to interact with the 360 environment around you. And finally, you have these VR computer-generated crisis management softwares, aka video game-like responsive immersive VR solution. So whether you're in a headset and running around playing a next action-packed game on PS5, or managing an airway injury in the trauma bay, it's the same thing, but that's most advanced level of immersion. So now, to go through some examples, I'm going to lead you through our very first VR initiatives back in 2014 at Sunnybrook. And at Sunnybrook, we have these cold steel elevators that patients take from day surgery to the operating rooms that we found were really scary. And many patients were really complaining about them. So I realized there was a niche when it came to preoperative anxiety. How can we reduce preoperative anxiety through immersion and educate our patients about their experience? Was a question that was going through my mind. Because anyone who's been to a hospital, whether or not you walk into one as a person who works there or as a person who is coming as a patient or a family member, you've probably gotten nervous. And the literature has shown that just walking through the doors of a hospital as a patient, 80% of patients have some form of anxiety, no matter what is happening on that day. Even look at me. I can put a line in most vessels in one's body, but I get lightheaded and can't look when I'm getting my blood drawn. So I knew preoperative anxiety is a big problem. So I looked at the literature and I saw that at the time, there's tons of literature using VR for exposure therapy in the psychiatric realm. And this is just a screenshot of the paper published, let alone years of body of work. So I thought maybe we can use this education tool for patients for the preoperative experience as a form of exposure therapy. So I saw VR's potential. But I, at the time, was more interested in fancy headsets and I wanted to use it right away. But then when I started interviewing our patients, I realized that it wasn't the correct approach. They couldn't access these fancy headsets at home. It wasn't authentic. So I just Googled what's the best 360 camera. And this shows in 2020, because every year, if you just Google it, you get 2021, 2022, 2023, 2024. I'm going to show you one afterwards. And I just started looking at how to use these 360 cameras. So we started filming preoperative experience to show to our patients before they came for their procedures. And then we started using it for education. And all of a sudden it caught on. And it was really easy to do. So all of a sudden the media started picking up. We started using it as sick kids. We started using Sunnybrook. And it was all from just a 360 camera and a Google Cardboard. But now we've progressed so far. Like even PC Magazine has articles on the best 360 cameras of 2024. You can buy a 360 camera just for photos. You have a 360 camera just for video and more. So we've evolved quite a bit and it's very accessible. Even the headsets have become accessible and have become more evolved from Google Cardboards and onto basically having processors on your head. So what we did, we filmed 360 videos and showed our patients how it felt to be wheeled from our same-day surgery into the OR, and I narrated it for them. And we did this 2 weeks before. I'm going to show just an example of this. So they show the fisheye lens, but when the patient has the headset on, they're actually in the first person on stretcher moving and being taken. So you can hear the bouncing of the, and I purposely didn't put any music in this because you can hear the bouncing of the stretcher, the metal clank, right? And then when you're coming to the OR, you get wheeled into the OR and see the bright lights, the cold, the room that it's open and vast, that's empty, that you're walking into, that's very scary. And we were trying to do this as a form of exposure therapy. And then we did this at Sick Kids as well.
Welcome to the operating room. Say hi, everybody. Oh, hi. As you can see, take a look around. There's lots of different stuff in this room. That stuff is not for you. Everybody here, though.
Hi there, my name's Lauren.
So we did this for kids so they can feel less nervous when they actually came to the operating room. And I'll give a personal anecdote. My daughter had urgent surgery at Sick Kids in January, and right away she knew that I don't want to walk into that room. I am very scared. She's 9, but she's like, I'm not getting into it. So I tried everything. You know, I gave her the face mask to let her breathe through it, and smell the Canadian Tire smell, and she was, you know, that helped her a little bit. And then she knew I've been doing this work for a long time, and she's played with all our VR toys at home. So she's like, can I watch that video? And she watched that video. And the first thing, you know, I would like to say that, hey, it worked so well and great. And for her, she's like, yeah, it helped me walk in. But the first thing she said after surgery, she's like, your video is old now. It doesn't look the same anymore. I think you need to change it. The ORs don't look the same. So you can tell that they get really invested in it, and it helps them. But at the same time, you have to keep it updated, and it makes it feel so real that they're like, I expect exactly that. So we studied this, and we looked at on the left at the Sick Kids data, and we looked at what the traditional thing is, looking at VR versus slideshow, which is what they usually use. And almost 92 or 94% child and parent prefer the VR tool. And then the bottom left kind of shows a heat map of what ages really it worked for, and that was from ages 6 to 14 on average, which really appreciated the VR. On the right is the data we use for adults, and on the top we looked at the visual anxiety scale, and we actually did something different where we had them expose them to the video 2 weeks before, and baseline, we had got their anxiety levels. After they watched the video, their anxiety levels all dropped, whether they're male, female, older or younger. And then the day of the procedure, we checked their anxiety scales again, and their anxiety scale came back up to baseline. So everyone's like, oh, well, you didn't really change it then. But think about it. Are you at baseline anxiety when you come in for surgery? You're probably through the roof. So my thought process at that time was that it's working. It's keeping us. Imagine what it was if we didn't use that exposure therapy. And the same thing, we looked at the same thing when it came to heart rates. What we did find was that females were a little more calm than males at the time. So that at that time, we were kind of pointing towards, we showed that we can change emotion and elicit fear in patients when in a controlled way, when it came to just basic VR 360 video and healthcare. So what about when it came to healthcare education? What about healthcare workers? And we were kind of forced into testing with the onset of COVID. We were noticing that a lot of the healthcare workers, with their altruism, were rushing into rooms when it came to crises without donning properly, without putting on their proper PPE. And that was an issue because they felt they had to get in there quickly, otherwise the patient's going to suffer, but they're doing it at a sacrifice of their own safety. So we took our 360 cameras and created videos where it kind of elicited the same emotion, the same stress of going into an urgent scenario, but while donning. So here I'm donning, and people are yelling at me, and I'm trying to go through the motions, and what we did is and they're trying to get me into the room quickly because the patient is deteriorating. And we showed these videos to our healthcare workers over and over again because we said we wanted to just basically get them nervous while donning, as if in the first person, so they can get used to the fact that they have to go through every single step properly and appropriately to not only help themselves, which would in turn help their patients. And then I have to highlight some of the great work that's happening in Ottawa with Dr. Glenn Posner here with VR 360 videos and teaching, because in this video, you can actually see that they took it to the next level because it goes to the plug of learning theory. So they're about to have a crisis in this scenario. The patient's not responding. And you can see it's 360, it's on YouTube, you can get to it. But you can also put captions, you can put text, you can interact with it. And you can look around, right? And this is kind of like when it comes to observational learning, the medical education theory of observational learning, you're taking and making it more immersive by adding these interactive points. Now, and a question I get asked is, how immersive can you really get with simple 360 videos? And I showed this video and I love it because this is a medical student we were just doing a simple study. It's a wayfinding spatial memory study where we're finding medical students were getting lost when they're coming to the hospitals. So we wanted to see if we can walk them through the hallways of the hospital with VR before they actually came, and they wouldn't get lost. It was a fun study, and it was something that we did. But what came out of this is this medical student was watching the video, and I want you to watch his feet. And he was so immersed in the experience that his legs naturally started moving as if he was walking himself. And I asked him about that after, and he's like, I didn't know. I just felt like I was walking through the hallways. And this was a simple 360 video with a 360 camera. And that's the difference when it comes to observational learning or modeling in the traditional sense versus what immersive 360 video can do. Observational learning on steroids. And because of that immersive feeling, we really start thinking about telesimulation. And I got to do another shameless plug. The team we have here at Sunnybrook Simulation, it was already pioneering different methods of virtual simulation through Zoom. And they've been experts in in-situ simulation already, so they took it to the next level. And they thought, like, well, how else can we push these limits? So let's start moving into telesimulation. And a telesimulation is not a new concept at all, but its rapid expansion and current use has outgrown its traditional description because of COVID. And most of the older definitions in the literature describe the requirement of bulky, expensive sim resources with instructors and students together, and that are not too far off or in remote locations. Up to 2017, there's no real unifying definition. And then along came people like the Sunnybrook Simulation Center who started pushing the limits, and we're trying to figure out what is telesimulation. So I really like this definition that McCoy proposed. The process by which telecommunication and simulation resources are utilized to provide education, training, and or assessment to learners at an offsite location. It's a purposeful, broad definition to allow for growth. And I bring this up because we're really going to show you examples of pushing the limits of telesimulation today by showing that this definition is all-encompassing when it comes to immersive reality. So we thought, well, why can't we use immersive reality for telesimulation, for live coaching or support with first-person guidance, or maybe just-in-time learning, single or multi-user? So this is an example of a study that's led by Dr. Niazi and the team at Sunnybrook, where they're actually, what's happening here is Dr. Niazi is on the right. He's facilitating as a regional block expert. He's in a headset, and what he's actually seeing is the learner on the left who's trying to do a nerve block with a 360 camera that we strapped to his head using 3D printed straps. And in the first person now, Dr. Niazi is now the learner. He can see what the learner is doing, feeling, moving, looking, and what they see in front of them. And he can guide them in first person through the correct method of how to do a nerve block. So that's what we thought. And the study is just wrapping up right now. I'll show you the data. I'll show you the data once I have it. But it's an example of live first person coaching. So imagine you're in a remote location and you are in a major trauma scenario, and you can call in to a major trauma center like Sunnybrook and speak to the TTL in the first person and actually have live coaching and tips as to how to do this. In the same way, when it came to COVID, we found that that when it came to the remote locations, it doesn't only have to be live first-person coaching, because there was a problem when it came to Indigenous services, Indigenous health populations, where they had to use oxygen concentrators because it was difficult to get patients who are critically ill long COVID out into primary care or tertiary care centers from the remote locations that we're in. So in partnership with the FNIHB in Ontario, as well as Indigenous Services Canada, the Sunnybrook Sim Center came up with a full just-in-time learning platform using 360 videos and 360 photos, where you could get oriented. You can use 360 images, you can use 360 videos, and log on at the time when you're ready to do it. So these healthcare providers at these remote locations were sent Google Cardboards, or they can do it on their phone as well, and log in and actually interact with these 360 photos to figure out how you can use these oxygen concentrators in an appropriate and safe way to help provide treatment for their patients. So we've kind of gone through the levels of immersion of VR. We have the 2D screen, we have the 360 recordings, passive 3D score. We also show the branch points where you can be interactive. But let's move on to the computer-generated crisis software area. So this is example, and if anyone's been to the ORs at Sunnybrook, this is basically mocked off of OR2 and OR4. And it shows
So on my left hand,
one of our first ones that we created, how to
is read the patient's
insert an epidural.
Computer does.
And you can move around in the OR environment. You look at our anesthetic record, that's exactly what we used to use. Look at the history and move on to actually getting the tools and the things together to do an epidural. In the same way, that's procedural, but what about when it comes to decision making? This is our mocked after our Sunnybrook trauma bay. And you can see that this is an airway injury patient. And in the first person, you can be immersed in this trauma bay. Not only can you put like an oxygen sat probe on a patient, you see that the monitors come on, he's desatting, he's down to 90%. If you move along, if you put oxygen on the patient and look around, you can move the monitors. If you actually put the oxygen on, you'll see that the monitors, once you answer the question, will actually oxygen saturation increase. You look in their mouth, you can mimic exactly what it feels like to have subcutaneous emphysema. And then if you really wanted to, you could do a fiber optic bronch with the video right there and manipulate it exactly how you would do it in real life. So that's how immersive you can get when it comes to crisis software like video games and actually do a fiber optic bronch. So let's move on to augmented reality. That's a whole run through of VR. So let's talk about AR. Augmented reality is basically simply overlaying computer-generated elements onto real life. If I was in person, I'd ask you, who here plays Pokemon Go or uses Instagram stories? And most people answer yes. But that's a very basic form of augmented reality. And I'm going to use AR now to show the different levels of immersion because I spent a lot of time in VR. So AR, you have the 2D screen again. You can look at your Pokemon Go, you can look at Instagram Reels, you can look at IKEA and put virtual furniture into your room. That's augmented reality, but using a 2D screen. Now, if you use a head-mounted display like the HoloLens or the Apple Vision, you can do simple overlaid elements that are non-interactive. You can make elements that are interactive. And again, you can make Crisis full-out software that's interactive. So this next video I like to show, it's pretty cool. It's from Pepsi. It's the first form. It has, for some reason, I can never get sound to work. For me, it does. I can hear it, but you guys won't. But just watch the video.
Different checks. That's the intro. See that? Okay. I can see what I'm doing. See me? I can do what I'm doing. Yeah. Check. Let me flip this script. I feel privileged for all who can witness this.
And that's just a form of augmented reality where they use a 2D screen with a camera on the other side and overlaid images. And see how immersive it was getting for people. They were like, oh my God, what is happening here? And this is just one of the earlier forms of augmented reality, which I always find this is a pretty cool video. Back then, there's another thing, you got interactive elements. So back in 2016, we got a HoloLens that I'm wearing on the top. And at Sick Kids, we just overlaid a puppy because we were finding kids who were very scared to run into the ORs. So they would chase the puppy onto the bed. And something very primitive like this worked so well. But that's an example of augmented reality with overlaying elements that are not interactive, but can be used in a healthcare setting. And then what about when it comes to clinical application? So this is Dr. Matava. He's my co-director at our immersive reality lab and one of the pioneers in technology in general in healthcare. And he's doing a nerve block, and he can oversee all his ultrasound images He's overlaid also. He's overlaid the patient's vitals without having to
Can
change
you
his head.
stream to back to the whole lens? See what you're capturing?
So the ergonomics of doing a nerve block all of a sudden has changed. He has everything in front of him. He doesn't have to move around. He's less bulky, and he can do the block. And say he didn't know it was a learner, he can have a video there that's overlaid, that's overlaid that he can watch to help him do the block.
Is that the
So we talked about when it comes to augmented reality, 2D screen, simple overlaid elements like what you saw with the Pepsi, we saw what you saw with the dog, and the interactive and manipulatable, like with what Dr. Matavo is doing with his blocks. But what about the actual AR computer generated crisis management software that you can actually interact with? What about the video games? And you know, there's an anesthesiologist here at Sunnybrook called Dr. Julian Wiegelman, named Dr. Julian Wiegelman, who's an amazing. I don't know how he has time in the world, but he is not only a great anesthesiologist, but he can develop software. He can be innovative in terms of ideas. And I want to show you what he's come up with that we've really leaned on when it came to our lab to do research with and use during COVID. So something called HoloSim. And it was based on an iterative process of design using content experts, tech experts, and end users, where we found that for it to really feel real and have an impact, it was beyond just seeing the patient in the operating room, but we need to manipulate the vitals on the real monitor. So together we did. And what Dr. Julian Wiggum was able to do, he made that monitor that you see in the background. I'm going to play the video in a second with the vitals. That's actually augmented elements, computer generated elements that are on our real monitor that felt real. So that we can interact with that. So you have the patient, you can listen to the breath sounds, you can see their color change. You can feel their pulse, you can get response. And then those monitors, the background that are beeping and everything, that's not real. That's actually overlaid on computer generated elements. And we use this not only for education, but we also use it for training of our intubation teams during COVID, because we had to mobilize really quickly. So obviously VR and AR is evolving, but this immersion, the sense of presence, interactivity has really evolved. And the benefits that I'm trying to say is immersion, and this immersion can lead to cost effectiveness over the long term. Development might be pricey. It's adaptable, it's customizable, and in medicine, when it comes to education, we know that knowledge is changing on a daily basis, and that's why we're lifelong learners, because a textbook just only gets updated so many times, right? But with virtual augmented reality as well as mannequin-based sim, we can combine all of them thereof and just continually update and continually educate all forms of learners. So let's get to number 3, appropriate application of appropriate learning theory, aka don't let the technology lead you. Now, before I can get into like the exact uses of VR and AR, it would be prudent for me to mention that the cognitive advantage it affords creating its usefulness. Whether you're learning from a textbook, walking down the street, or observing a preceptor, or simply watching a video, or if you're Newton with the apple falling on your head, as individuals, we must construct a 3D world of all the input and sensory input that we're getting. And that takes a lot of cognitive load. And the greater the cognitive processing power, the more it is difficult for us to actually take in those specific elements. And a colleague of mine, Dr. Walter Tavares from U of T, as well as Wilson Center, a lot of us work on this. So we're working together on a lot of immersive reality and how to reduce cognitive load when it comes to how the technology affects the learner as well as the teacher, because we want to make it simple. So you can overlay elements in a progressive fashion when it comes to immersive reality, so that the cognitive load can only be matched to the type of learner. A junior learner might not have the capacity to take on so many different elements, while an expert can. So not only does VR and AR potentially help learners make sense of their surroundings and learning objectives, it's a bit easier titrating and customizing it to the environment, but also forces them to construct their learning in order to really understand and promote long-term retention. And this is what we call constructivism, where you're taking all this input and kind of making it a scaffold in your brain. And constructivism outlines that learning occurs by amalgamating previous knowledge, input from all senses, emotions, new information to create or construct meaning and concepts from the educational activity. And immersive reality really plays well into that fact, because meaningful learning occurs when learners take an active role, interacting and manipulating the environment through decision-making and navigating the complexities of the scenario. And speaking of meaning, that leads to storytelling, which I think is amazing when it comes to immersive reality, because immersive reality really allowed us to take part in engaging, interactive storytelling, which is a medical learning theory in itself. Imagine being placed in the middle of a trauma resuscitation, not watching as a bystander, but in the first person as a trauma team leader, as a surgeon, as the anesthesiologist, as the AA, as the nurse, in leading the resus, seeing, hearing, and emotionally feeling everything that's happening in that scenario. How much do you think that would impact retention versus just watching on a passive video? But despite the advantages I've spoken about and how we can use cognitive theory to our advantage, we're stuck kind of in the peak of inflated expectations. We're trying to avoid the trough of disillusionment, like I alluded to earlier. And the major reason for this is what Zhu outlined in the Immersive Reality Review. They found that all the papers they included in the review, few papers actually mentioned using learning theory to guide the design or application of AR for healthcare education. So we're kind of putting the cart before the horse. And it was being used across many different siloed applications, and just based on the see one, do one, teach one kind of thing that we were somehow can't get rid of. And this is the same way that was used for technology. So they went on to describe 3 important layers. The foundation being learning theory, and then comes function, and the last finally comes outcome. So not doing it for the sake of doing it, but doing it because it's a cool technology. It's foundation with learning theory, then function, then outcome. And when it comes to looking at the software tools and the history and the literature around it, I kind of trying to look at, well, does this really work? And I look in 3 different domains. One is clinical reasoning diagnosis that Epstein kind of outlined. Non-technical skills, so communication, behavior, changing behavior, leadership, problem solving, and then technical skills, so procedural based. So I'm going to start off with technical skills really quickly and just glance over it, because even without me saying anything about the haptic skills, technical skills is where kind of everyone has kind of jumped on immersive learning. And there's abundance of literature out there, hundreds and hundreds of papers. It's easy to create a 360 video or an immersive video game to teach a stepwise procedural skill and show that it has impact on learning of the skill. So I'm not going to focus on this too much. But what about changing behavior and non-technical skills? Can it really change behavior? And this is an older study, but I love using it because I'm going to show the video in a second. And this study kind of looked at whether medical doctors would take the virtual situation seriously. So they knew this is VR. I'm not showing the head, but of the participant who's a GP. They have a headset on, virtual reality, and they're sitting in a room. And what they see in a 360 environment, they have someone, a patient and their daughter, who are trying to get antibiotics prescribed for a viral illness that they clearly know it's a viral illness and we shouldn't be prescribing antibiotics for, a common case. So look what happens.
Sometimes we can do delayed prescriptions, but I've examined your mum right now and she looks fine to me. And I think this is a virus.
Doctor, maybe you can give us a prescription or do we collect it if my mom gets worse.
He's thinking about it. He's on edge. He's nervous.
Okay. It seems like that's something you're both
and he gives in.
Absolutely fixed on having. We can arrange for a prescription that you can pick up tomorrow or the next day if things are getting worse.
Reassuring as I can. I do not think that there is.
So I love that. I love the study because it's done really well. And they know it's not the right approach. They know they're in a VR environment. They know they're dealing with avatars that have physicians that are speaking for them. And yet, because it feels so real and so tense and so nervous in that environment, just like what happened in real life, if you're in a GP's office, they gave in. And they found that the majority of trainees and 7 of the 12 qualified GPs all gave in. So can it really change behavior? Yes, if done properly. Now, I only present this slide because I feel it's prudent in the current climate, and I'm not going to spend too much time on it, but I feel it was in this platform, I should use my platform to say, with all the injustice happening here and the rest of the world, it's important to really think about and be reflective and consider how culture affects patient care. I'm going to let you read that quote, because we have to start thinking about race, religion, gender, sexuality, age, experience, background, language, everything, and how it influences who we are as healthcare providers, as learners, as patients. And they're often stereotypes that must be abandoned while working with other professionals. But how many Black, female, brown-eyed, Asian, transgender mannequins have you seen actually in use? Can immersive reality really change that? Because Dr. Cogniglaro answers that question by shining a spotlight on the fact that sim technology lacks diversity. Can immersive reality change that? And the use of virtual reality, and there's a quote where the appearance of avatars can be easily altered, may allow clinicians to gain a deeper understanding of their own values and how these affect their clinical practice. And I want everyone just kind of take that away a little bit too and think about how do we approach this? And we're talking about intelligence-based design is how do we approach our own biases as well as our biases that we have when it comes to education and simulation, as well as with our patients. Now let's move on to clinical reasoning diagnoses. And these are 2 old papers, and I keep them there because it hasn't changed. And that's the sad part. And I know these are from 2010, 2012, but a 2010 meta-analysis of the literature on virtual patients demonstrated overall a large positive learning effect of virtual patients compared to no intervention. Okay, well, we know that if you teach someone about any topic in any way, there'll be some learning, an element of learning, but it showed a small effect when compared to other types of teaching. This meta-analysis also kind of illustrated the majority of the published research was not able to include, they were not even included due to everyone's heterogeneous study design. But then this trial and 11 others were included in a more recent meta-analysis of efficacy of virtual patients in medical education that was published a little later. And it only included randomized studies and included a clear positive overall effect compared to traditional modalities. But was that really clinical reasoning or decision-making or procedural? We don't know that. We don't know what type of, what they were actually assessing because there's such heterogeneity in the type of papers. And I think the focus shifted to let's start creating and doing and see if it works afterwards. And I think that's very dangerous. And I think that's the barriers we're facing in knowledge translation when it comes to immersive virtual environments. I remember running into Dr. Gaba at one point at a conference, that, you know, the godfather of mannequin-based simulation and the work. And he was even excited about virtual reality, augmented reality. And I asked him, like, you know, I remember you published a lot saying, you know, we should do this intelligent design and all that. And he's like, yeah, you're right, completely right. But right now, it's kind of first to market. I don't care about the evidence anymore. I just want to do it and see what happens after, and we'll figure it out. Which caught me off guard, right? If Dr. Gaba is saying this, oh my gosh. But I kind of disagree and agree, because if we don't do it, it's never going to get done. But at the same time, if we don't really think about how we're doing it, it's never going to get used. So we're kind of on the fence. So then I saw an integrated review in 2014, and it's the broadest type of research method because it includes all various research designs to more fully understand what the phenomenon or concern is. So there's 3 qualitative papers here. There was 20 quantitative and I think 2 mixed studies included. But again, they said the same thing. It lacked theory and pedagogical framework and lacked objectives which were created post hoc after they was already made on the scenarios. So that's kind of the problem that I've been saying. It's still considered a novelty because we aren't really creating in a way that's based on sound learning theory and really looking at the outcomes afterwards. So what I'm trying to say is, although promising, I don't know why this is being cut off, but the literature to date doesn't really show consistency of the prototypes, and they lack educational theory and heterogeneous approaches. So we need a common language. We need a common goal, probably more robust studies based on learning theory. And most of the stuff has been done procedurally. But what about more crisis management or decision-making or changing behavior and non-technical skills? So last, before I finish, let's talk about practical considerations. Look at this technology. It looks so cool and impressive. And I'm going to look at this and I'm going to say that, would you be surprised if I said everything you see on this page, no one uses anymore? It's outdated. It's more than 5-6 years old, but it still looks cool. And what I'm trying to say is, don't get bogged down by the technology. It's going to change every year. The next Quest is going to come out. The next Google thing, next Meta thing is going to come out. The Apple, it's all going to come out every year. Don't get bogged down by technology, because if you do, you're going to get lost. You're going to make for one thing, and that's it. You're going to develop, and you're going to get stuck in that, and you're never going to move forward. Don't worry about technology. Kind of focus on what I've said in this whole presentation about how to create these tools so that they can be adaptable for any technology, but also they impact learning. You know, we started off with this HTC Vive back in the day with this headset that's strapped to a long wire to the ceiling and these things. And now you have the Apple Vision, which much, you know, completely cordless and combines AR and VR, which might change things completely. But what you really need to figure out is how to build a nationwide network, or a network to help you move this technology forward of resources. And the great thing about this technology is that I've been fortunate to hire video game developers in Toronto, to work with people like Petal and Walter and Yuki and the Sim centers across Toronto, and having a great team at the Sim Center in Toronto, at Sunnybrook, and working with the Ottawa Technology University, or with Bill Capelos, and creating a lab with sick kids. And because I couldn't do this by myself, I'm a starving academic. I am an anesthesiologist. You got to form a team, and that includes whether it be collaborating with industry, collaborating with universities, collaborating with other sim centers and other knowledge users and tech experts, and then getting your developer teams. That's when you come together and really push this forward. And it's not as difficult as you may think. Collaboration is key. So what I like to say is, don't let the technology lead you. And I urge you, and I leave you with the motivation to help us move this past the peak of inflated expectations to the plateau of productivity. Thank you.
Thanks so much, Fahad, for that wonderful presentation. Very enlightening, and certainly you touched, it was a very balanced argument for the technology. Just gonna make sure I give you my round of applause emoji.
Thank you for listening.
So, perfect timing. We now have a quarter of our allotted SimCity rounds time for questions and interactivity. So I invite you to turn your cameras on, and let's pick Fahad's brains on virtual reality technology. I felt a stab of pain when you showed all the headsets and said, believe it or not, these are all obsolete, because like we still have those.
So do I. We're still using some of them, but like if you get bogged down with that technology, don't get.
We bought 20. We have 20.
Yeah, exactly. Right. And
right.
you Petal, you of all people know that it gets updated every 6 months to every year, right? So it's more like let's look for it and see what the basic principles are, and the foundation is that we can use this for.
Yeah, it's just moving in leaps and bounds, just like the iPhones, quickly becomes obsolete. People are lining up in front of the Apple Store, and Jabin and Lennox are here, and I was invited to a tour of the Sick Kids Sim Center, and I saw their tethered headset and what the capabilities of their sim, their virtual reality sim, and I was like, wow, because we had to do a really painful conversation to create that conversation in psychiatry sims. Was very time intensive.
And
labor,
And on just on that note, Clyde might kill me for saying this, but when my daughter had urgent surgery in January, I actually asked her, I was like, hey, do you guys have any more headsets for, can we show them these videos? And they're like, the technology is not really working right now. We haven't updated it. And I'm like, that's knowledge translation. That's the issue we have. So I had my phone, I had my own go to the car airport, but that's just an example of how technology can quickly get outdated, but that shouldn't stop you. It's more, if you built it for the foundation, you can move on to the next technology and use the same thing, and don't get bogged down by that tech.
Hi, Lennox. Anybody have any questions or comments for Fahad?
Maybe I'll ask a question. For those who don't know me, Lennox Fong, I'm a sim enthusiast at Sick Kids, and also an intensive care physician and a CMO too. Interesting enough, there's some work that's going on, sponsored by some industry, to try and really launch this in different ways. And I know one of the questions they're looking at is barriers or facilitators for implementation more broadly, because as you've highlighted, like there's the technology comes and go, where it feels like we're always playing catch up, and even when we do have something that seems to be fairly sticky, it is not easy to get it in place. So I'm curious, from your personal experience, what do you see as some of the big barriers that are out there for more broad adoption? I mean broad in the beyond a sim center, but in healthcare more broadly.
I think that there's different levels of barriers, tons, unfortunately, but one is the tech, depending on where you're going, right? Is there access to basic Wi-Fi? Is there access to basic internet or data, or let alone 5G, 3G, whatever it is, and can it run that, right? That's the first principle, foundational question that you kind of have to ask yourself, that we were even dealing with. And Agnes, Susan, and Tarsila, and Victoria, and all of them were really dealing with this when you talk about remote populations, right? Like, well, what kind of data do they have? How easy is it to get? So that's the first question. I think that's a big barrier, right? Although, as you probably already know, it is getting easier with Starlink, with all the networking that we can able to get across the world, whether you like Elon Musk or not, but it's making it more accessible, right? So that's the first foundation. And the next thing is, okay, does everyone really need a headset? Does everyone really need a Google Cardboard? Like before, we used to really hype up Google Cardboard. It's easy to do. It's a couple dollars, send it down to them. But now Google's kind of like decommissioned Google Cardboards, right? And it's hard to use that videos, those cardboards. Sometimes we have boxes and boxes of those sitting around in our sim center, and we're like, okay, what do we do with these now? But at the same time, it hasn't changed the fact that you can still use it on your phone, right? Even though it might not be as immersive, right? So when you develop that, I think one of the barriers is, can you use? Do you need a headset? Do you need that tech? Do you need that money? If you can get one headset, that's fine, and that could still be used, right? Another thing is knowledge translation when it comes to actual leadership and policymakers, right? Is, do they believe in it? Do they want it to be implemented? Do they know what it is? And leading that way, right? I think a big example that I say is when I first started in this realm, and I started really pushing VR and ARs, and I wasn't selling it as the be all and end all, but I was like, we should kind of help me get this going, like using our pre-anesthetic clinics. And the thing that we found was that leadership teams weren't really listening, because you can't blame them, because they cost money and they don't know what it is, right? And you can't blame them at all. So what I did is I reached out to media and said, hey, look at this cool thing that we're doing, right? And the Toronto Star picked it up, and Globe picked it up, and all of a sudden leadership star came over and said, hey, what are you doing here? Why is it in the news? Can we help you with that? And we got a foundational donation, we got a foundation grant, right? So it's kind of being strategic, and you can't blame senior leadership, because they have their priorities when it comes to healthcare and patient care, and they have so many things that you just kind of have to put yourself on the radar somehow. And help have them, and you won't be able to see without this universal adoption, without even their local, I don't say buying, I say ownership, because that's what it is. Not buying into the thing, is taking ownership of it with you. And then when you're talking at a broader scale, it's more fostering those collaborations, those networks again. So where you can work with the on the ground change makers in South Africa, in Pakistan, in the area, I'm just saying places that we've worked with, and say, okay, here's the change makers, and here's your ROI on how much that costs, and you're a CMO, like I'm speaking to, like all of this. I become you to ask you all of this, right? But that's to show that the low hanging fruit, like 360 video, costs us next to nothing, and this is the impact that it's happening. Now you help us get to the next level, where we will collaborate with industry. Everyone's to help you do this, right? And everyone's afraid of industry, and there's a lot of obstacles there, where I get emailed by industry partners or potential industry partners once, twice a week, asking, hey, can you do this with me? Can you do this with me? And it is what it is. I think 1% will finally actually be real and have a foster collaboration that's great, and you have to sift through that, right? And yes, they want to make money, but at the same time, it could be a quid pro quo, where you're helping each other develop this thing that can actually help a proof of concept, that can help, and also, make them money, and also bring money back to the local site, or the local South African site, or the local site, your research lab. We've done that, where we've done a few things with the industry where they've made a few dollars, but they've kind of thrown it back to our research lab, develop more, so that they can move on to the next one, right? And that's where your discussion with IP and your go on. And that's kind of my long-winded way of saying, you have to kind of build those foundations, the collaboration, foundational collaborations. And I think you should have industry involved, because you're not going to be able to do it yourself, right? And I don't think even hospitals or senior leadership can give you enough to do that, right? I think you have to foster strong collaboration with the industry, as well as the people in the trenches, where you're trying to move this beyond just your local site, as well as the tech, deficits. I hope I answered the question, but it's a lot. That's a seminar in itself in terms of like knowledge translation when it comes to this.
And just to put a shameless plug for our November SimCity rounds, where KMH will be presenting on our virtual reality suicide risk assessment, opioid overdose. And I like Fahad was a brilliant segue to that, because you talk about pedagogy, you talk about having that gap between wanting to disseminate it, right? But then not necessarily having tailored it to the people that you want it to be implemented in. So there's pros and cons, like you pointed out. We did base it on needs assessment, but then once it costs so much, right, that eventually when we want to disseminate it, it means we either spend more money to then do another iteration, do more sort of adaptation, or perhaps you build something that could be more generic or easier to implement, and you target it at a particular level of training per se. So for instance, with the suicide risk assessment, we were able to embed it in the Faculty of Nursing curriculum, and we've had contacts from other countries asking about the opioid overdose. But like you said, when we went to the UK, the NHS reached out, we had a meeting, and they're like, what papers have you published on the efficacy, right? Because they need to take that, right, to justify their expenditure. So I think that, like you said, there's a lot of, players and a lot of balls in the air that have to be, juggled to get these things up and running.
And I'm going to do a shameless plug for you. I think what you guys have done at CAMH is probably steps beyond what many people in the world are doing when it comes to leading knowledge translation in VR and AR. And anyone here, I would say bug Jameen and Pedal, like everyone, like they've already, the fact that you're speaking to the NHS, the fact that you're speaking to that is beyond what most people can achieve. And it takes time and effort to do that. So,
but now I've got my eye on the augmented reality that you've talked about. I feel like there's so much potential there. And like you said, the 2D, the 360 videos, how do we know they're not as efficacious in what we want to achieve, right? We don't know.
Yeah, you don't know. And that's all you really need, right? So
right. And it would cost way less, and it would be easy to make another video and adapt it to a different cultural context, right? So I think we're in the beginning stages of a very exciting journey, and you have really done a wonderful job today. Moni, I see you turned your camera on. Did you have a question?
I did. Thank you for letting me finding the button for my hand. My name is Moni Frick. I don't know any of you except for Sandra Bechevel. I'm Sarah Wilkinson. I'm from the University of Manitoba.
Welcome.
From the Office of Interprofessional Collaboration here, and a physiotherapist by background. So certainly we're delving more into using simulation, VR, AI, in terms of preparing our students for team-based care. And I'm also looking at it for physiotherapy education. And just one comment, this last year we were working with a Canadian company, Lumetto, you probably know it.
Lumetto, yeah.
And one of the problems I had with them, I wanted a Latino man as my avatar, and they didn't have it yet. I ended up with a Black woman because they didn't have enough diversity yet developed. So it's in process, I agree, but it's not ready yet. It seems to me that the development platform, at least Lumetto, they're still early on maybe in what they're doing. And so they didn't have the diversity that the specific case that I wanted, I had to modify, which was easy, but I think that is still just developing. And my background is in Indigenous health, and actually using this for anti-racism, non-technical skills with the potential is huge. But again, I don't think they're there yet in terms of having First Nation avatars that use AI, or whether we prescript it, to have that back and forth, which is fascinating. I think we all struggle with this. Our learners, our postgraduates struggle with this. So potential is huge. I'm wondering how much you've been working with Cash at U of T and thinking about, or the other networks, the other health network in Toronto, around team-based simulation. That's actually my question. Around, have you had much exposure to that or much practice with that yet, and how's that working out for you?
So team-based simulation includes immersive simulation or mannequin-based or anything?
Actually, I'm thinking VR.
Yeah. So what we're trying to do now is get multiple people involved in the same virtual environments simultaneously, right? Just in time or not just in person. So if you have multiple healthcare specialties that are all managing the same crisis situation, whether it be communication or whether it be an airway injury, we're trying to figure out how to get them in there and elicit the same emotional responses. So we're actually just about to start a study. We're going through ethics right now for that, looking at, because the software wasn't fully there yet. And Pedal, you can speak to this because you've been doing this a lot, right? And trying to get multiple people in the same room and be able to believe that that person in front of me is that person, is we were finding obstacles to that, but now it's to actually come along quite a bit. So we're just starting. So I can't say we've been working a lot with it when it comes to changing team-based learning, but we're starting to. We're getting there now. We're trying to run a study. Pedal, I don't know if you...
So Moni, I think we should set up a meeting to chat about this further, and I would encourage you to email us. We'd love to chat more.
Well,
We're
actually,
on-
as it were, I'm coming to meet with Cash this the week after Thanksgiving weekend. I'm going to be in Toronto, so I'll be at U of T. Perhaps we can set up a meeting.
Yes, so email me. I'm happy to do that. I want to thank Fahad formally again for his time and his wonderful presentation. I want to put a plug for the Global Network for Simulation in Healthcare, GNSH, is having their annual meeting here in Toronto, not to be missed if you're able to attend. And then our next SimCity Rounds is October 10th. We'll be having our first external presenter for the year. It's Professor Andrew Teodorzak from Australia, and he'll be his titled presentation is Potential for Artificial Intelligence and Virtual Reality in Undergraduate Geriatric Medicine Education. Thanks, everyone. Have a great week and have a happy simulation week, as per Agnes. Bye.
Thank you for having me.